Welcome. Good afternoon. We're excited to have another series of patient case discussions today. My name is Suresh Ramalingam. I'm a thoracic oncologist at Emory University's Winship Cancer Institute. And today I'm joined by a fantastic panel of multidisciplinary experts focused on thoracic oncology. And I'm going to allow them to introduce themselves. First, let me start with Dr. Michelle Ginsberg.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging and Vice Chair for Education at Memorial Sloan Kettering Cancer Center, and also Professor of Radiology at Weill Cornell Medical College.
Hello, I'm Dr. Seth Force. I am the Kamal A. Mansour Professor of Surgery and Chief of General Thoracic Surgery at Emory University Hospital in Atlanta, Georgia.
Hi, thank you, and good day. My name is Dr. Wally Curran. I'm a radiation oncologist and the Global Chief Medical Officer of Genesis Care and Professor Emeritus at Emory University.
Hello, and good afternoon. I'm Tom Stinchcomb. I'm a thoracic oncologist at Duke Cancer Institute.
We're going to go over some very exciting cases. We have a wide array of cases today that represent important clinical considerations and contexts that we face in our clinic. So this is an 82-year-old male who has been diagnosed with metastatic lung adenocarcinoma involving the right lower lobe. The patient had presented with back pain and what seemed to be an L5 vertebral metastases. Let me give some additional details before we start talking about the next systemic therapy recommendation for this patient. So this patient presented with symptoms of dry cough, low back pain, which was radiating around his flank on the left side. The patient had a performance status of 2 on the ECOG scale. The patient's past medical history included hypertension and abdominal aortic aneurysm. There was a 60-pack year smoking history. The patient was a former smoker. He's a retired Army veteran. No family history of lung cancer or other pertinent malignancies. The patient had an MRI of the lumbar spine, and I'll show you the images in a second. There was also a CT scan of the chest, abdomen, and pelvis, and a PET scan. So I'm going to invite Dr. Ginsberg to review the images with us.
We see that the L5 vertebral body is replaced with tumor. The marrow is replaced, and it extends as well into the left pedicle and transverse process on the axial image, which is the one on the bottom right. There's no epidural invasion on these studies. The CT of the chest in the top right-hand corner demonstrates the 2.7 centimeter spiculated nodule in the superior segment of the right lower lobe. There was no lymphadenopathy on the scan. Beyond the L5 vertebral body metastasis, there was no other metastatic disease demonstrated. And the SUV max of the nodule on a PET was 8.8, which all of these are consistent with the primary lung tumor metastatic to L5.
So it sounds like an oligometastatic disease situation, Dr. Ginsberg. Would you agree with that characterization?
Correct.
Okay. So the patient underwent CT-guided core biopsy of the L5 vertebral body, and the diagnosis was metastatic adenocarcinoma. Immunostains were positive for TTF1 and napsin-A. The patient also underwent biopsy of the right lower lobe lung mass, which confirmed the diagnosis of a well-differentiated adenocarcinoma. Further testing was done, as is considered standard in this setting, NGS, and this patient was found to have an ERB2 V842 mutation. The other driver mutations, EGFR, MET, and so forth, were all negative, and the PD-L1 was negative for this patient. So the situation here is that the patient has pain, has been diagnosed with oligometastatic disease, and obviously with this patient presenting with symptoms, the question would be, how do we palliate this patient? So Dr. Curran, can you talk to us a little bit about radiotherapy approach for this patient?
So I guess the first question is there an indication for surgical decompression as opposed to a radiation approach? it states that the patient wasn't interested in it, but I think it is important, Dr. Ramalingan, for the caregivers to get a really detailed history as well as great physical exam of the patient to see whether they believe there would be value in the more immediate decompression of a surgical procedure. If the patient has numbness and objective weakness of the lower extremities, if there's a rapid progression of these symptoms, then it's something to consider. Now we heard from Dr. Ginsberg that there does not appear to be epidural effect on the cauda equina, which is great. So I don't hear a story about the need or a strong indication for surgery. On the other hand, every caregiver really has to get a good detailed history and even see how well the patient walks, because testing strength in a supine position is very different than getting a person to ambulate. If there's a clear indication that if the non-operative approach is decided on, that radiation should be given and should be given in a efficient and prompt manner. SBRT of 30 gray and 5 fractions is a great regimen. There is some data to suggest that you get more durable relief and quicker relief when you use a higher dose per fraction than a standard non-stereotactic approach of 30 gray and 10 fractions. So I think this is a good approach, and hopefully the patient would benefit from it.
Thank you. And the next question then is systemic therapy after you have taken care of the L5 problem. Dr. Stinchcomb, what's your approach to systemic therapy in this situation?
So I think the first triage point is, does he have an actionable oncogenic mutation? And he doesn't. So at that point, the question really is immunotherapy alone. So I look at the PD-L1. In his case, I used the cutoff of 50%, and he was below that. So that leaves us with a chemo-immunotherapy combination is what I've generally used. There are a number of different combinations available to him. His being an adenocarcinoma, I would probably use the carboplatin, pemetrexed, and pembrolizumab at the Keynote 189 therapy at this point.
Now, this patient has the ERB2 mutation. How do you interpret this mutation? Is this something that would play a role later in the course of this patient's therapy?
I think it would. I think it's not the classic ERB2 mutation, but it is an ERB2 mutation. And we know that recent trials of a single-arm phase 2 trial of Trastuzumab Deruxtecan, recently published in the New England Journal, showed very impressive response rates. But patients enrolled on that trial were patients who had progressed on a platinum-based chemotherapy or second-line patients. And so I think that's something I would make a mental note of, right, and consider as an option if first-line therapy is not successful.
You mentioned, sorry, Dr. Karan, go ahead.
So going one step back, and I apologize for interrupting, just want to review again what the extent of the disease of this patient in the chest is with Dr. Ginsberg. Could you just remind us of that beyond the lower lobe lesion?
We only have a right lower lobe mass, but no lymphadenopathy in the chest. So it's an isolated lesion with no lymphadenopathy in this oligometastatic disease.
So one of the questions, in addition to thinking of the best systemic therapy, is there a role in this particular patient of either a surgical or a radiotherapeutic approach to the patient's primary lesion, given that this is basically one primary lesion, no nodal disease, one, to the best of what I've heard, metastatic lesion, and could that put the patient in the best position for a longer progression-free survival?
Yeah, Dr. Karan, thank you. That was going to be my next question for you, since there is an ongoing NRG oncology trial. So why don't we discuss potentially the role of surgery first with Dr. Force, and then talk about the role of radiation therapy in this situation. So Dr. Force.
Sure. So the role for surgery in stage 4 lung cancer is pretty limited But there is a role in certain situations. Primarily, that's been with isolated brain lesions that have been removed, and then the only evidence of cancer is in the lung lesion. The typical approach has been the resection of the brain tumor followed by chemotherapy, and then if no other disease shows up, then resection of the lung lesion. To a lesser degree, isolated adrenal metastases have been dealt with, not with the same results, but if that can be done, particularly if it's the only area. To a much lesser degree, we would consider resection with bony metastasis, because one of the caveats with that is you're not removing all the cancer. You're treating all the cancer, but you're not removing it, as opposed to an adrenalectomy or resection of a brain lesion. So not that it couldn't be done, and it would be done in the same manner, where it would be localized radiation to the metastasis followed by chemotherapy, and then if no other metastasis showed up, considering surgery. But if you're going to radiate one area, locally, it seems like it doesn't make sense not to treat the lung lesion, then give the chemotherapy. And then if it came back again, just in that lung lesion, they could always have surgery. So this would not be someone I would be excited about, right after they have their radiation to their spine, doing surgery, holding off on chemotherapy or anything like that. So I think it's unlikely we would offer surgery to this patient, but we never say never. It can always be done.
Thank you. Dr. Curran, let's talk about radiation in this situation.
Right. So, this is a little different type of scenario than what you referred to, Dr. Rumlingen, as the energy study looking at the role of radiation in oligometastatic disease, because we're really thinking of how do we treat the primary tumor in a low volume metastatic setting. I do think the patient's ability to have long freedom from progression could be improved. Could is the operative word, if that lesion is addressed by either radiation with an SBRT type approach or surgery. And I don't have a preference. It's really what's logistically and medically easier for the patient, the caregivers. I don't have a strong feeling as to whether it should be done before or after the start of systemic therapy. The recovery from the radiation to that lesion should be pretty prompt. So one argument would be do the stereotactic treatment of the L5 lesion, do stereotactic treatment to the lower lobe lesion, and then just move on to the best systemic therapy. That would be efficient. Another option would be give the immunotherapy, use the primary lesion as a indicator of responsiveness, and when and if it's appropriate, use SBRT or surgery to consolidate that response. But the trial you're talking about is really asking a broader question, and that is, in the setting of a patient with metastatic non-small cell lung cancer, where a systemic approach might involve chemo, immunotherapy, or immunotherapy alone, what is the role of using SBRT to a small number of lesions as a way of improving progression-free survival and perhaps even survival?
Thank you. So, Dr. Stinchcomb, when this patient presents to you to talk about systemic therapy, you recommend chemo and immunotherapy. The specific mutation in this case you mentioned is not the typical HER2 exon 20 mutation, right? This is an exon 21 mutation. And this patient wouldn't be the one where the Trastuzumab Deruxtecan data that you referred to would be applicable to, correct?
Most of the patients who were enrolled had the classic HER2 exon 20. I think there were a few patients with included in that trial that did have some additional mutations, but I think the concern is that that's a very small sample set. What is the activity of this combination in those people, the atypical mutations at this point? So I think it's something I would make note of before starting the first line therapy, just so I don't forget that on subsequent things, and take a closer look at HER2 directed trials as well as the Trastuzumab Deruxtecan.
Yeah, I think as we think about first line therapy for this patient, the ability to know whether your treatment is working or not would be the biggest consideration for deferring radiation, at least for the time being, and from my standpoint. And after 4 cycles of chemo, if it's working, especially if you're using immunotherapy, because you're subjecting that patient to potentially 2 years of therapy without knowing if it's working or not. What are your thoughts on that?
My practice has generally been to do 2 or 4 cycles, get a scan, and then after that, consult with my radiation oncologist about a consolidation approach, because I do like the value of knowing whether the patient's responding to the chemo-immunotherapy.
Hey, Ram, on this slide right here, it says the patient's deciding between systemic therapy or close observation. It looks like with only having received radiation to the metastasis. What would you tell a patient who said, yeah, you can radiate the metastasis, you can radiate the lesion, but I don't want any systemic therapy? How would we counsel that patient?
I presume this patient's decision of close observation versus systemic therapy comes from the fact that the patient is 82 years old and perhaps has a focus on quality of life and not wanting to go through chemotherapy. In the setting of PD-L1 negative tumor, immunotherapy alone is not an option, an effective option. And this patient would need a combination approach like Dr. Stinchcomb mentioned, which is chemo plus immunotherapy. And if the patient, after a discussion of the pros and cons of potential side effects of chemotherapy and immunotherapy, and the option of getting radiation and following on close observation are discussed, I think it's very reasonable if the patient decided not to get chemo, just to follow after you radiate the primary tumor also after you've done the L5 radiation. So overall, very interesting findings in this oligometastatic disease patient. Clearly, consideration of surgery for somebody who presents with this sort of a neurological, potential neurological situation, and radiation in the form of SBRT, followed by whether you consider radiation to the primary tumor, as well as systemic therapy or systemic therapy first, and later on primary tumor, are considerations to talk to the patient and discuss in a multidisciplinary tumor setting. Any closing comments on this, Dr. Karan?
Great discussion, and it just shows us the complexity of care, but how important it is to have the caregivers communicating with one another as well as with the patient and his family.
Thank you.